to be vulnerable, tend to be hampered in terms of what they can say and how vocal they can be. Now, I'll give you an example of why that becomes important. The Commission on Dental Accreditation, CODA, is the entity that that has almost a monopoly on the accreditation of dental schools, dental assisting schools, dental hygiene schools. And it sets the policy for accreditation, and dental schools are reaccredited every 7 years. And that's a big deal because schools take 2 or 3 years in preparing for those reaccreditation visits. About 15 years ago, CODA established a couple of standards on diversity. And of course, we celebrated that. It was late, but we said it was about time. We now have standards in diversity. In the 15 years since those standards were adopted, recognizing that in that time, each dental school has probably been reaccredited twice. No dental school had ever been cited for lack of diversity. Now, we know, I know, won't lay out names and get into all that there are dental schools that have little or no diversity of students, little or no diversity of faculty, yet they pass. So diversity in those instances has come down. I'm wearing black socks, you're wearing green socks, you're wearing red socks. Oh, red socks, that's a. So we've got these difference of socks, and we're obviously diverse. Well, the National Coalition of Dentists for Health Equity took exception to that. Now, again, it was the only organization that could do that because it had no particular skin in the game and could not be reached out and retaliated against. We sent a very strongly worded letter to CODA, respectfully written, as Dr. Drake pointed out, but very firmly worded. We know that they have taken that to heart, and we are expecting a response from them later in the next couple of months. We're prepared to take further action if we find that that response is below our expectations. But that again is the type of thing that has to occur. It may not be innovative, but sometimes you have to put yourself in a position where you can stand on a platform where you are basically out of reach to say what has to be said, take a stance that needs to be taken for the sake of changing policy and moving forward. So I will leave you with those opening comments, and I will then turn the microphone to my following colleagues, and hopefully we can follow up on some of this discussion in our discussion period. Thank you very much. Thank you, Fred. Appreciate it.
Well, it's the Kaz and Kaz show here. Thank you. And this is Matt. Hi. So let's see here.
Say that to me.
That's the cooker. Yes. Which one blows it up? Well, where did that? Thank you. Thank you. Thank you. Hi, everybody. What a pleasure. What a privilege. Might be the Kaz and Kaz show, but they're giants among giants, and Dr. Evans is one of them. So lots to talk about. I'd love for us to maximize our time together and just dive right in. So at CareQuest Institute for Oral Health, we approach our work by really approaching and centering towards systems level change. And what does that mean? For us, it always begins, the whole work from alpha to omega begins by what we call 2 acknowledgements. One is that the current system isn't working for everyone because it wasn't designed as such. And it has to begin by confronting and acknowledging that our current system is really broken. The code and the construct have historically and repeatedly left out the same in certain populations, and we have receipts. So when the system limits access, in this particular case, in dental insurance, we'll have massive disparities as a result of those artificial barriers, forcing those with the greatest needs to have to go to ED for dental care. And because the system is siloed, and because it comes with limitations around scope of practice and modes of practice, and it's going to be unlikely to offer actual dental care. So instead, our populations who are having to go to the ED to receive dental care, they end up with a script for opioids instead of actually receiving care. And there's cost to these. Productivity loss annually associated with untreated oral disease amounts to $46 billion. An annual cost to emergency departments for what I put in quotation marks, non-traumatic dental conditions is $3.4 billion. The economic burden of health disparities is $451 billion. And here's the thing, it amounts to almost $1,400 per person. And the interesting thing about the $1,400 per person is this is irrelevant and regardless of individuals' race and ethnicity and their political stance, and also what they think about equity and social justice. So it is a load that is actually spread out. So as you can see, incentives and opportunities for innovation are bound, but it's how we show up and how we center health equity and equity in our work that'll translate into systems change and progress. And we aim to reconfigure the system into the future where it doesn't just include those excluded, but one where disparities are addressed by reprioritizing and reallocating resources. We recognize the dynamics of our space where the one constant is change, and the journey towards system change demands iteration, agility, and nimbleness. And to that end, foresight from data is critical, but we make data informed, not data-driven decisions. And the difference, of course, is the context and texture that our communities add. Foresight that tells us where the headwinds are and what the evolving policy and payment and market environments are that can support innovation. And we center community voice. We work to develop deeper understanding of what the communities value and what's standing in their way of progress. From their perspective, that is. We zoom out to identify similar or national trends to ask which communities have been able to overcome these challenges. What are the lessons to learn, to share, and to amplify? And we also know that innovatively solving tough problems require approaches from multiple angles, leveraging all the tools in our armamentarium. So when we discuss our work at CareQuest Institute a little bit later, you'll see a thread of both centering community voice and innovation that really connects all of our core functions. And when we talk about centering community voice, we mean business. Stickiness of a solution, no matter how innovative, demands that it meets the values of its beneficiaries, nonprofit work included. We assess the utility of solutions, be it policy, be it advocacy, grants, research, education, you name it, against this very tool that you see. But not so much as a pass-fail mechanism, but more of a, how can we iterate and innovate on this approach so that it is contributing more to the agency and power of the community? So how do we do our work? Well, we have five what we call core functions at CareQuest Institute. Analytics and data insight, which shed light on and inform our entire portfolio of work through quantitative and qualitative insight. They focus heavily on local communities' priorities and lived experience. And here, we lean into participatory research approach. We also understand that bulk data demographics sets us up for one-size-fits-all solutions. We need to have visibility onto those shouldering the disparities, knowing that many organizations are still inconsistent in data collection practices. As you can see from Ernst & Young Health Equity Report, if I knew Jabe was going to be here, I would have quoted Deloitte, but I got all the love. For real. So we've begun to incorporate disaggregated demographics into our work, which allow for that granular visibility into the barriers and disparities with which communities contend. We can't say anything these days without mentioning AI. We certainly can't mention innovation without AI. And I got to recognize Dean Ginobili, who's not here right now today, but a lot of folks from HSDM are here, who boldly led the first AI symposium last year here at HSDM. And it was an amazing conversation because it really didn't just talk about opportunities in AI, which is really easy to jump into, but it really also talked about really the barriers, right? And how what we feed into it is going to spit it back out at us, and why it's important for us to be intentional about this work. So big props to the Dean. We're really excited about potential of its future iterations of this work. We recognize that awareness is the first step to systems change and maintaining momentum towards system change. And that is that elusive sustainability piece that everyone talks about, right? Let's get fired up, ready to go. But are we going to stay fired up and ready to go? Demands training, education, future leaders, which is what the work here is right now. And the apostles of this work that will go on to carry the message. And well, since 2021, we've held 60 webinars. We've had 150 different speakers with some of the quants that you see here. Well, and the universe is sure as heck telling us that education and speaking truth are paramount and needed more than ever. As of April 2024, approximately 250 local, state, and federal government entities have introduced bills, executive orders, and other policies that restrict content of teaching and training related to race and sex in public schools. Currently, 10 Republican majority state legislatures have passed bills constraining the use of specified divisive concepts in teaching and mandatory training in public higher education settings. But Dr. Evans talked a little bit about policy and advocacy. Our advocacy leans on grassroots networks across the country. Local political nuances and landscapes vary greatly from one state to the next, but it is the network members and advocates who've demonstrated incredible capacity to navigate them and advocate successfully. We ask what the values are to these communities and empower them to lead. And we're constantly asking ourselves, who else might have insight? How can we include them in the process? And if they have a seat at the table, is that meaningful? Were we intentional about that? Are we going to keep the seat for them while they're gone? Priority issues for the communities are quite often centered around access to care through expansion of coverage through Medicaid and Medicare. And despite these local variation, there's a lot of overlap and commonality when it comes to effective paths to policy development. And they're always the ones that are led and informed by the local voices and priorities. With nearly a decade of incredibly forward-thinking and innovative initiatives across the US, our health transformation team has led in interoperability, care coordination, and value-based care space in oral health. We're proud of the deep community engagements that we've developed, transformation we've seen in ways providers interact and engage, and lives that have been touched as a result of this work. So naturally, our next leap of innovation will be to consolidate and scale these learnings into one-of-a-kind curriculum based on our deep expertise in this area. Now, I cannot wait for the opportunity to be able to share this with you all. Work and development, incredibly exciting stuff, more to come. And this one we're gonna love, our friend and my fellow Buckeye, Dr. Derek Gray's in the house. And once reminded us here, in this very room, as a matter of fact, I'm fairly certain, commitment without cash is counterfeit. Thank you, sir. Well, we are committed through and through. We innovate in space of philanthropy and grant making, and so that we support groundbreaking, equity-centered initiatives, ideas that work to defragment healthcare system, develop culturally responsive workforce, focus on lifting up underserved populations and communities, and cultivate a network of advocates that advance health equity. Again, you see this mirroring right here. This is the work that's being done right here, and those apostles that we talked about. We fund initiatives and programs that focus on systems change, but we explicitly and quantifiably prioritize those that incorporate the voice of community within their work. Those closest to the problems are closest to the solutions, but the farthest away from agency and power, and we mean it. For example, if there is a proposal for community health worker training program in a high-need states, has the community been involved in development of the solution? How does the grantee see itself in moving the needle? How do they see themselves as change agents towards empowering the community that it's serving? Or if it's a pilot, we see a lot of pilots. We call them dine and dashes a lot. You come do the pilot, thanks for your work, and we're out of here. I saw a lot of that personally, unrelated to CareQuest Institute in Haiti. You show up to the internally displaced people camp, and I'm not going to name names, right? The organization, global organizations know who they are. They come do the work, they do the pilot, the photo ops are done, and the community is left holding the bag and trying to figure out what to do with those USAID, there I said it, tents at the IDP camp. Sorry about that. Sometimes I don't know what happens to me. And finally, CareQuest Innovation Partners, which is the leading edge of mission-centered innovation, and in collaboration with CareQuest Institute, our sister agency, if you will, advanced our mission by identifying and accelerating emerging innovation through validating the impact and business case, supporting minority founders and marginalized communities, convening and activating commercial decision makers with paths to impact vast resources and scale. We do this through our SMILE program, which is now in its third year and is the first of its kind startup accelerator for oral health, or that interface of oral health and physical and behavioral health, the outer rim, if you will. And we ask, how do we make oral health more accessible, equitable, and integrated? Take a sip of water here. I love this meeting. It's called Black Resilience, Innovation in the Midst of Resistance. This was created by a New Orleans-based artist, Mr. Kenneth Scott Jr. So looking in the immediate future, we know that 2024 is an election year. And while we're not here to prognosticate about the outcome and talk about what the political landscape looks like in 2025 and beyond, what we do know is that progress is not a linear process. And that every hard-fought victory should be backed by vigilance and resilience to protect it. And so with that in the back of my mind, I've been asking myself, can resilience be seen as innovation? Can innovation perhaps be defined as maintaining our resolve, engaging our communities, digging deeper? It's playoff time, playing hard defense in the paint. Innovation is often seen as a new way of doing things. After all, it comes from the word novus, for new. But perhaps at a time of political headwinds, we were talking about them earlier, we should look to innovate new solutions and renew our pledge and purpose by reminding ourselves of our deeper calling and understanding how the gradual but seismic shift occurring before our very eyes can and will impact our communities, and remembering what it's taken for us to get to this point and remaining committed, steadfast, and proactive. Thank you all.
Thank you so much, and a tough act to follow, guys. Yeah. Right. Yeah. No, full.
There we go. Thank you.
And then it's really quick.
Yes, there is.
No, you're fine. Okay, perfect. Okay. Thank you so much, and appreciate those words, right? It's really about being resilient in this landscape. So thank you guys so much for having me. I'm Ariana McGee. I am the CEO and founder of Navigate Maternity. We are a tech-enabled medical device company, and our flagship product is our remote patient monitoring system. that empowers care teams, stakeholders, payers, healthcare systems with the data they need to improve perinatal outcomes. Before we get into what Navigate is and really how it sits at that intersection of innovation and policy, I want to tell you guys a few stories. Click before it gets there. Thunder. Okay, there it goes. Yeah, perfect. So this woman, her name is Louisa Bowers Calloway. She was born prior to the end of slavery, an enslaved Black woman in Louisiana. She birthed over 11 children to 2 different white men with no agency of her own body. And through her birthing her own, swath of children, she also became what we now know as a granny midwife. So she went around her community and birthed babies and helped to give agency to Black women at a time when she herself did not have any agency. When the licensure changed in the state, she was not licensed, and as a Black woman had to become licensed, which was a heck of a feat. She was able to do so and is considered to be one of the first licensed midwives in the state. This woman is my great-great-grandmother. And her legacy really informs the work that we do here today at Navigate. So to give you a bit more context about myself, this is my family. I come from this big brood of folks, as I was saying, right? It's a swath of people. And my great-grandfather descends from Louisa and John Peyton Parker. He had this wonderful family. And as we heard President Drake state earlier, there's something about when you have this family, right? You have this solid foundation of people. And my great-grandfather provided that for his family. My grandmother, Vanita, helped to raise me alongside my mom, who was a single parent. She encouraged my mom to go back to school. My mom finished as a 2-time grad from University of Michigan. So sorry for the Ohio State people, but she took me back as a toddler while she went straight through to finish her bachelor's and then went straight through to finish law school. So seeing a woman do this and use the strength and the foundation of her family once again inspired me that I can do it. So the early years, I went to Indiana University. I have a degree in theater and honors English. I had a great, amazing experience there, Pledge Delta. So I don't know if there are any stores that are in the room. But I moved to New York City and quickly, I started out in theater and my parents, my mom especially said, hey, I'm gonna give you this much time and then you gotta get a job. And I was like, okay. And that day came and she was serious. So she cut me off. So I said, wait, I've gotta get a job. But how can I merge my background in theater and helping people, right? I always wanted to be able to make an impact. And I found that to be in healthcare. So I started out at Alcon as a rep. I had the West and South Bronx and Harlem, and it was a really great experience. And I learned firsthand what it meant to have health equity at the forefront, listening to our patients and bringing them solutions that they actually need. Well, it can't be all work, right? You've got to have a little play. And I happened to find love in the city. So I met my husband. He is not Italian, but I love this movie. Bronx Tale's a classic. So I met my husband, AJ, and he actually was there doing research. He had just finished med school and was kind of beefing up his CV for the match. And we found love. And then, first comes love, then comes marriage, right? So my husband then matched for residency out in Colorado. So we moved to Denver and I was also working. And then, what they say, love, marriage, then what comes next? Babies. So the babies came and they did not stop. So our first 2, we had Jade in 2018, we had Trey in 2019. I still was working, then transitioned, worked at Genzyme, worked at Biogen, started to kind of work in global market access consulting part-time. And then here comes another baby, 2020. So in 2020, we all know what happened, right? That was the COVID-19 pandemic. Well, at this point now, I had been a high-risk mom. I had 2 prior C-sections in the 2 prior years. I was, scared to death during this pandemic while being big and pregnant. And I was supposed to have all these extra touches. And all of a sudden my doc said, okay, well, no, actually we're going to do telehealth. And I was like, who's touching me, right? Like, you have no data on me. And if I didn't live with a physician, I would be scared out of my mind, excuse me. And that's what made me think about other moms, right? What are they going through right now being pregnant during COVID? And that was the first spark for Navigate. And here is Naomi. This is our third. That's her personality today, guys. And then, if y'all could believe it, number 4. So at this point, we had our 3 babies, 2018, 2019, 2020. 2021 rolls around, and on my birthday, I find out that we are once again pregnant now with our 4th baby, and I slid down a wall. And I was scared. I was like, I've had 3 prior C-sections, there's just no way, I'm not a year postpartum. This is just too much. And I was also relocating. My husband had now matched for fellowship, and we were relocating from Colorado to Indiana, which is number 3 in the nation for prenatal postpartum death. And as a Black woman, going to a state with a really poor outcomes, I was scared. And I had a great doc who assured me, you're going to be fine. Like, don't worry, we're going to have baby. Well, 2 days prior to my scheduled C-section, the worst thing possibly happens. I ended up going into labor. I started to contract. I was having cervical changes, and my husband was away, but my mom was with me. And so she said, we're going to go in. You're about to have that baby. We go in, we're met with a very tired on-call doctor. She walks in the room, she claps her hands, and she says, all right, Mom, I'm sending you guys home. She doesn't say hello. And right then, I kind of knew this wasn't going to go the way that I thought it was going to go. And I explained it to, no, I'm high risk. I've had 3 prior C-sections. I'm contracting, just call my doctor. She says, I'm not going to do that. It's too late, and you need to leave. And my mom was there. And as I said earlier, guys, she's a lawyer, and I'm an only child. And so, yeah. And she, was kind of listening. And then my mom stepped in and she said, absolutely not. You will not let my daughter and my granddaughter die here today. She's high risk. You need to call her doctor now. And they proceed to go back and forth. And my mom, she really stood her ground and advocated on my behalf, and really, thank goodness. So once my doctor hears the workup, my doc rushes in because she's like, absolutely not, that patient cannot go home. She comes in, my husband races home. They get me back to the operating room. They open me up and they uncover that I have a uterine window so large you can see my daughter's hair. I was hours away from rupturing. And it is an experience when your doctor looks at you over that curtain and she says, we could have lost you and baby here today, that everything becomes crystal clear. And thank goodness, Aliyah was born, and she's healthy, and she's happy, and she's spunky, guys, because she's 2. So, but it's something happens when you yourself almost die. So it was through that experience that really codified starting Navigate Maternity. So this is our core team. Prior to that experience, we had already kind of started the beginning workings of our company, but we, after that, decided to go full time. I'm a mom of 4, but I've also been in the healthcare space for over 12 years. So I've worked at a multitude of different companies, from sales to global market access consulting to market access strategy, heading US market access at what is now the 4th largest med device company globally. So deep expertise within the space. Thea James has worked on the payer and the hospital side of things. Dr. Harris has her executive MBA, sits on the policy board for ACOG, has been practicing for over 14 years. And then Corey Wolfgang has been in the space for over 20 years. So we've got a great just core team, and we're committed. I have a great board and ad board. I won't run through all of them, but just know we've got some amazing folks on our side helping us develop and really iterate on what it is that we've currently built. I will give a shout out to my mom. She's on our board, Leslie Wise. So very appreciative. So let's revisit the problem. Again, I'm probably preaching to the choir, but let's just level set. So the US has the highest prenatal and postpartum death rate of any high resource nation globally. Black women like myself are dying about 3 to 4 times that national average, and Indigenous women are dying about 2 times that national average. This is a stat that always gets me though. So I was born in 1990. It was safer for my mother to have me then than it was for me to have my daughter 2 years ago. This death rate has more than doubled, and per the CDC, at least 84% of these deaths are preventable. Now, I do want to caveat, we just got the latest findings and we have seen an improvement in our numbers, but really it's kind of level setting from COVID. But what has not improved is the disparity, right? Like the disparity between Black women and our counterparts is still staggering. So we've got a lot of room to make improvement. So my team, we've identified 4 key clinical gaps. So number 1, a mother's touched about 14 times during the prenatal postpartum journey. And then these are just snapshots. Secondly, that drives reactive care. So we typically are doing something once we know something. And then third, capturing social determinants of health in a systematic way. And lastly, implicit bias. So how do we replace that subjectivity with objective data? That's a problem we've got to solve now, right? This is a huge $25 billion problem. And Roe versus Wade is gone in much of the country. I live in Indiana. It is gone. And so I've heard some other folks talk about in this room, what do we do when we live in these red states and we have this policy now that is affecting our capability to take care of our patients? This problem, maternal health, is only going to get worse. So what are we going to do about it? So that leads me to our core technology here at Navigate. So we've created this comprehensive provider dashboard patient app that interfaces with our suite of FDA cleared hardware. One of the other things, and we actually just recently added this, is that we are now, as we have mental health and validated social determinants of health screenings, we actually partner with local partners in that area to help pull mom through. So we can not only identify the problem, but help solve for that problem. And then close that care loop back with the healthcare team, with our payers, so that they know the interventions that are taking place. In our kit, we have an FDA cleared Bluetooth blood pressure cuff. It is one of 2 cuffs on the market that's actually indicated for use in pregnant, pre-eclamptic, and postpartum women within the home. That's a huge feat, guys. This meets an ISO standard that most cuffs don't meet. We also have weight monitoring, depression scoring. Our software is built on a certified EHR backend. So all in all, we really empower care teams, stakeholders with the data they need to better manage perinatal populations. Again, we kind of talked about the cuff and what sets it apart, but how does Navigate work, right? Like, how does it actually work? So what we do is we contract with either our payers or our health systems. We then train our care teams to prescribe our product. Then as they identify a mom that would be a good candidate for it, they prescribe her a Navigate kit, at which point mom gets set up with her kit. She's using her app, she's using the hardware. That data pulses through back to our care teams. We have our own patient navigator, and we help to support the care team if there's anything missed. And all in all, we, then if there's an issue or if there's screening, then we connect them to that local partner. We really want to be that support system to offload physicians, because we understand that you guys are facing burnout. And that's one thing, Dr. Harris, our CMO, as we were building this, we did a lot of interviews with OB-GYNs. Actually, most of our early investors are Black OBs, because they saw the value to say, wait, we need some help here. We need something to take this extra burden, and making sure that we definitely kept that lens. And so let's get into the policy. So policy right now is actually, we're ripe for innovations like this. In 2021, there were only 3 states with expanded Medicaid postpartum coverage. And to give you all a little bit more context, and this is my market access nerdy girl hat on. Market access and reimbursement is the lifeline to innovation and scalability. You cannot scale a technology without reimbursement. It's just not, it's not feasible. So when we're talking about women's health, not just perinatal health, but women's health, 49% of perinatal or childbirthing is paid for by Medicaid. So CMS pays for that. So that means that you can't bring an innovation and not have something that can actually be used by that patient population. So all of these, direct to consumer products or products that, Medicaid will not pay for, that means that mom cannot access it. Well, now we have, and to update, it's now 45 states where we have expanded postpartum Medicaid coverage. That means now we are paying for mom up to 1 year postpartum. So now she can get the care. Now there's reimbursement so that we can actually bring the innovations to help better manage mom and improve the outcomes. And what's the impact of all of this? It's not just Navigate. There are other companies like ours that are in the space. I mean, Dr. Fleming, I've heard of your company, and it's, and all the amazing work that you all do. This is really about how we can impact the ecosystem, right? This is about not just that we have a product or we have a home health system or whatever it is, it's that we can actually feed the data to all the necessary stakeholders so that we can all better optimize resource allocation. We can inform and use that data, not just to understand the data, but make it actionable so that we can improve outcomes. This is some of the traction and the accelerators that Navigate's done. I've been with the company a little over a year, and in a year's time, I heard Dean Reede talk about this faith. Faith, guys, nothing but. In a year's time, we've raised over $2 million. And as Black women in medtech, almost unheard of. And so, the fact that we've had all these great companies invest in us, help us, mentor us, it's really been impactful to our business. And all in all, Dr. Evans, you actually said this earlier, we can be the change that we want to see. Health equity, we all know that it is under attack in our country, period. So we have to figure out ways to deconstruct it, in the words of our previous speaker, and figure out ways that we can continue, though, to push the envelope, because we can make it happen. Our predecessors, all the giants in this room have done it prior to us. We all have the power to also do it. So thank you. Thank you so much.
We are going to ask our speakers to come up front. I'm hoping y'all have questions percolating. So if you have a question, you can come on up to the mic. It's always great, Dr. Hodge, when it comes together, right? It's like we did it on purpose. So and so we're really excited. I just to do a little bitty recap as people come to the mic, starting with Dr. Evans and really talking about policy change is important, but we also have to have implementation and accountability, right, to make it work. And then Dr. Rafia showed us how to put policy in action and connect it through the sectors and really put capital with the commitment, right? And so that's really important. And then thinking about Ariana's comment, so of course, all of that was great. But I think it's really important. I really talk a lot about reimbursement reform, right? And we really have to talk about, especially in the Medicaid space, especially for women's health in general, it's just terrible across the board. And so we can continue to have great innovations, but we have to also work on the payer space at the same time if we really want to impact the communities that we're talking about. So with that, we'll go with our first question.
Thank you very much. Very interesting. Again, it's not long enough. We've heard one form or another in many of these things, and it's time to get it done. When I became dean of the School of Dental Medicine, Joe Henry was the interim dean the year before, and he saved the school. It was a time that some major dental schools closed, like all of Chicago, Northwestern, Washington University, Emory, all the dental schools closed, and it was a sad time. He talked about innovation, but there were many enemies of innovation, and sometimes the organized things that Dad spoke about of the people, to not only throw out there one thing, which is more innovative and more helpful to help patients, dental therapists or dental implants. Which is better for taking care of patients? Electronic health records or spending more time on oral health rather than dental manipulations? Thank you very much.
I can certainly comment on the dental therapy piece. Just as background, as workforce has changed dramatically, certainly in my career period, in medicine, with the emergence of physician assistants, with the emergence of nurse practitioners in various specialty areas now. That major change has had a profound effect upon the medical system. Many of us interact with a nurse practitioner or a PA, and the physician is sort of in the hinterlands and called upon when actually needed. Today, as we speak, the dental workforce is no different than it's been for 100+ years. You have a receptionist, typically. You have a dental assistant. You might have a dental hygienist, and you've got the dentist. Dental therapy started years ago in New Zealand. It's practiced in about 100 countries now. And these are people that are trained at I don't know how to really describe it, maybe at a year 2 or year 3 level of what a dental student would be trained in. But they provide essentially primary dental care to patients. And dental therapy has now been passed by state legislatures in 14 states. So that's more than a quarter of the United States. However, I hate to call it organized dentistry because that means that I'm not organized. I would say that principal dental organizations, which is essentially the ADA and its various state affiliations, fight dental therapy tooth and nail, pun intended when I say tooth. But it's where the public and where this is all hinged on states where it's been the public, the community, talks about the oral health inequities that they face, the lack of access to care. And there's no response to that when the question comes, when the issue is raised that dentists in these states are the only workforce category licensed by the state to provide that service. So again, in principle, as I mentioned earlier, in principle, the thought would be, well, if your group is the only group licensed to provide the service, then you should have a moral and ethical obligation to ensure that service is available to everyone. But that is not the case because there are innumerable barriers that have been supported. And I talk about everybody's got there are entities with stakes in policy and lack of policy. So there are barriers, there are evident barriers that have already been mentioned this afternoon to access to care. And it's the dental therapists that are providing a bridge, and it's not the solution, but it's part of the solution. It's a step forward. Interestingly enough, I'll just end my comments with this. There's now a fledgling movement to advance dental therapy in the state of Illinois. Why is that important? That's the home of the American Dental Association. So that has really sparked a lot of interest. I should add that as we speak, Minnesota, the state of Minnesota is the most experienced. They've now got about 140 dental therapists practicing in the state one way or another. No way in the world has the dental care, the oral health system in Minnesota crashed. There are other states where dental therapists are actively engaged, and those systems have not crashed as well. Patients, however, have now access to care. Communities of need have providers that can address at least some of their needs, not all of their needs, but some of their needs. One closing point, when dental therapists are licensed, they take the exact same licensing exam that dental students take for the range of services that dental therapists can provide. So they're licensed in no different way and under no different standards than our dental students relative to, or the dentists, relative to the services that dental therapists can provide. So I'm so pleased that that question came up and gave me an opportunity to respond.
I'll just add here, in Oregon, I was the state representative for the Rule Advisory Committee that established the scope of practice for dental therapists in Oregon. And so I'm intimately aware of the contentious nature of those conversations and why it was important. The federal recognized tribes that we have in the state of Oregon were a really huge, powerful voice and a force behind the training and having this movement, if you will, in the state of Oregon. And oddly enough, there was, through that friction, a sort of an agreement was made towards moving forward with a dental therapy scope of practice in the state. I'll just add though, my own particular take on that question is like the meme that you see is why not both? So I don't think to me needs to be a binary choice. And it speaks to sort of an innovative mindset towards solving problems. It can be both. I think one shouldn't just detract from the other firstly. Secondly, I think it's important to have adequate investments across the board, both on the policy side, on the service delivery side, on services and SaaS, and really broadly speaking, adequate resourcing and putting your money where your mouth is sort of a thing. It's going to be critical. So the workforce issue is important, needs to be addressed, and there's other items on the table to go around.
Oh, no, well, thank you. Good afternoon. Thank you all for very informative presentations. I think we're supposed to confuse ourselves. So I'm Chantal McGee. I am the Chief Medical Officer for the field. So I am considered a payer. And so I do have a few questions, but I'm going to try to summarize it into one. I am concerned about the ethical application of AI as well as innovation. Right now, if I was to Google something, I would get what are the most frequently used engines rather than in sites that people go to. So I'm not getting a comprehensive picture of what the information that is out there. So many of our patients go to Dr. Google first. And so when it comes to generative AI, it's based upon what's out there, but also about what has been prioritized. And I think we need to speak to regenerative AI as well, but I don't want to get into the depths of that. I guess my concern is when we speak about innovation, disruptive innovation, oftentimes those that are most vulnerable are the ones that are most impacted, oftentimes in a negative way. Our objective does not always align with the outcome. I am concerned, particularly when it comes to remote patient monitoring, that it will be used as a proxy or surrogate instead of getting that type of relationship with a provider for those who live in rural areas, for those who are facing health-related social needs, whether it's transportation, whether it's hours of work, whether it's competing priorities. We're going to relegate them to working through a 2D platform where someone will then try to put a Band-Aid on something that probably requires a more in-depth evaluation. And I am fearful of that because oftentimes we look for short-term rather than long-term implications of something, right? We say, okay, we have a near-term cost, look for the near-term outcome rather than looking at the long view, which we were so instructed to do earlier. So I want to know what safeguards do you have in place in order to assure that the appropriate populations can use it as an additive tool, but it's not meant to serve as the primary tool for these populations? Because in your harrowing narrative, you were in the room with the physician. I can only imagine being in some 2D platform trying to express, if I don't have the lexicon, if I don't have the health literacy, if I am relying on this as my primary mechanism of communicating with a provider. So I just want to know what safeguards in place when it comes to not just your product, but products in general, and also how are we going to assure that people are making informed decisions when it comes to generative and regenerative AI? I think I spoke too long, but you guys.
So, thank you, that was a really great question, so I'll try to break it up. So to answer your first question regarding like remote patient monitoring, it being the primary modality for which patients interact with their physician. I think part of it is that when we have products that don't interface with the physician responsible for mom's care, so to your point, maybe some of these more direct to consumer products, where they're just like, use our platform and interact with the doc that's whoever or wherever. And this data never actually gets moved back to your care team, to the people responsible for your care. That's when I think that those issues. I think that when you implement products like remote patient monitoring, not as something to replace, but something to actually help and be additive and be support, that's when it doesn't become the primary mode, but it becomes an option inside their toolbox. As you stated, especially those rural patients, and living in Indiana, you know, we have a lot of rural care districts, right? Where moms are living 30, 40 miles away from their nearest doc. Having remote patient monitoring in that case with actual validated hardware for use within the home helps to support the doc. Because otherwise, then that patient becomes a black hole, right? Like you don't know what's happening with mom, with baby. It doesn't become something that replaces the doctor, because it couldn't. Just like your point, there may be other issues that an app, software is not going to be able to pick up. But what it can do is provide you more data points, so that instead of you seeing mom once a month and you only getting those snapshots, you're actually getting, wait, I saw that on Wednesday, I'm getting a note that, wait, her blood pressure was sky high, her symptom tracker said this is happening, and okay, no, I need to bring her in. But it still allows the physician and the caregiver to be in the driver's seat, just with better tools. Hopefully that answered your question. And then the second part of it regarding the AI, I'm right with you, right? There has to be safeguards, because we understand that there's bias in AI, and especially with the vulnerable patient populations. You know, there are so many different things, even from a language standpoint, right? I mean, we saw this on the SAT years ago when they were like, well, Black students weren't doing as well on it because the lexicon in which they were using, like, we do not associate those things. It didn't mean we didn't understand, or it was a measure of our intelligence. It meant that socially and culturally there were gaps, and at the end of the day, that test couldn't measure that properly. It's the same thing with AI. There are going to be social and cultural gaps that AI is not going to capture. And so that's why we have to create or support innovations like ourselves and others that are capturing data on diverse patient populations, so that we can build AI with those data sets. I think that is the big gap currently in AI, especially within healthcare. So hopefully that answered your question. Yeah.
Hi, good afternoon. My name is Phoebe Walters. I'm a pediatrician training in adolescent medicine. About 2 weeks ago, I moderated a panel after, based on the documentary Rebirthing Justice, which is actually where I learned about the 84% that Ariana, you mentioned, being preventable. And actually that really stuck with me. And then your story about being in that room, and as an educated woman, but then you require for your mother, who's a lawyer, to stand her ground. You know, and I appreciate all the work that you're doing, but I just always think about my teenager who's pregnant, or even 30-something-year-old woman like myself who can be pregnant, and a doctor tells me, you're going home. What are we doing in addition to providing them with the services that you're providing to empower women, because it's obviously Black women are the ones that are suffering very worse when it comes to maternal and child mortality, but all women in America are dying, all moms. What can we do to empower them to say, no, I know my body, and I'm not gonna go home, because I don't think a lot of them will do that.
Yeah, no, I'm 100% with you, and actually, I see she need to really take that question, because there are amazing other groups that help women do that exact thing, right? Help them with the tools and the education to empower themselves, right? For us, we focus on making sure that we do give moms a platform, literally and figuratively, right? Where they have an opportunity to be able to communicate directly with the care team. And then there also be some administrative oversight to that, right? Because part of it is this, I can advocate for myself. And oftentimes then it turns into a she said fight. Well, I'm saying this, and then the doctor goes back with, whether it's her administration or so forth, that, well, no, this didn't happen that way. Then it becomes very subjective. So I think in order for, empowerment is key, but you also have to have the data, right? And then that data to be able to drill down to say, no, this doctor took this step and was not listening. And not just as we see patterns, And so once we have data like that, that's what we're hoping will help to change. And then the quality measures, and for all the payers that are in the room, then the quality measures and the incentives and the deans on payment, that will change behavior.
If it's okay, I'll just add here, one of my rallying cries when I get on my soapbox is a representative workforce. When you see a provider who looks like you, has had the same life journey as you, has seen the same obstacles as you, they're more apt to open their ears, their eyes, and listen and feel for what you're going through. So the representative workforce component is a critical piece of this answer that we're seeking. But the one step above that is something that we're here talking about, the systems level change and showing resilience is a reproductive freedom component. This is the kind of conversation that we're going to have more of because of the constraint that the system is placing on us. So I think at a micro and meso and a macro level, there's multiple ways to approaching this. Great question.
Hi, everyone. I'm so happy to be here. It actually took me a lot to get here, so I'm very grateful that I made it. So I wanted to just represent for the reproductive health space, maybe address, I know they weren't addressed to me, but address some of the comments that were made. And just like to give my one plea, if anything. So right now, reproductive health, women are in deep crisis. I know that there are a lot of important issues in the health equity space. But I would argue right now where women are, especially reproductive age women, I think should be first and foremost on everyone's mind because it impacts everyone in this room, if not personally. I know somebody has a daughter, cousin, sister who is able to get pregnant. And I practice now in North Carolina. And I will tell you every day I go on call, I am fearful. I will tell you, last week or 2 weeks ago, I had a 15-week patient with broken water sent home. So this stuff happens all the time. And so what my kind of, desire to see from the health equity space is that we embrace innovation a little bit more. And so what innovation means is, number one, recognizing no one solution is going to solve every single problem, right? No one company can solve every single problem. This is a multifaceted, problem, and many people are going to have to come in to do this. And what I advocate for all of us to do, especially those of us with means, is we really need to put our dollars and our hours into supporting these groups and people doing this work because no one's coming to save us. If you look at the political landscape right now, it is clear nobody's coming to save us. We have to save ourselves. And so what that means is we need to invest in that infrastructure, and we need to invest in that infrastructure now. And so to the point made about monitoring, I understand that caveat, but we're not talking about, is it a provider or a monitor? It's really no care for 9 months, or can we have some monitoring? That's really the decision that we're making. That same night that I took care of that 15-weeker, a mom full term, or what her dates were actually were, hadn't had any prenatal care, came in hysterical, blaming herself, saying I'm the worst mother ever, because she was having a baby. This was her 6th or 7th baby, and she never had time to go to the doctor. Didn't have time. And so what do you tell that person? What do you offer them, right? Because we can say, yes, you can go to this appointment and have all of this face time with the provider, but she worked a job at like Chick-fil-A, at the local Walmart, at Waffle House, she literally was telling me about all her 18,000 jobs that she then walks to, throughout the day. And she has 6 kids at home to take care of. How is she gonna get the care that she needs? And so when I ask all of you to embrace innovation, it's really thinking about that, right? And so no one solution is going to fix every single problem. To the other point that was made about what do you do when the provider, so that's one of the things that we're working on, right? So we are working on that exact scenario. How do you support women in obstetrical emergencies, right? And so we have a team that comes in of physicians, anesthesiologists, lawyers even, to do just that. So when the doctor says you need to go home, you have a team of people who are telling you, no, she's not going home. And if you send her home, we have an infrastructure in place. But this is the ecosystem that we need to build, right? Because we can't do it all. Like, it is very hard to start a company, I'll tell you that. It's very expensive to start a company. And you really have to drill down on your niche and what part of the problem that you're going to solve. And I'm very grateful for the work that Mary's company is doing, the work that Ariana's company is doing, because it helps us supplement the ecosystem that we are creating, right? It makes our solution more meaningful if those other solutions are already in place. And so I ask us as a community, as a health equity community, to really embrace innovation. And some of that means putting faith in others, knowing that all of these questions won't be answered right away. But we have to have a little bit of faith in one another, because we are at the point of crisis, especially in maternal health. And so whatever anyone can do to help to support either, teams working in here to support people working outside. Getting people to the polls, anything that you can do, if you love the women in your life, this should be a priority for you. And I'll get off my soapbox.
Thank you. Oh, I'll introduce Dr. Yamishi O'Connor. She's also a Reede Scholar and clearly very passionate, like we all are, about maternal health. After Henny, I'm going to have one final question for the panelists, and then I'll bring Kim up. Okay.
Thank you. Hi, my name is Henny Hayon-Hong. I'm the current Commonwealth Fund Fellow, and I'm also an emergency medicine physician at Boston Medical Center, which is the largest SafeNet hospital of Boston. So I deeply care about maternal health, but I'm going to shift the gear a little bit into oral health. As an ER physician, as we saw earlier from statistics, every day and night, we see the impact of the lack of support in oral health in our public health system. In the emergency room, I see this just every shift. I think the most recent shift that I had last week was during 8 hours, I think at least out of the 30 patients that I saw, at least like 7 patients had oral health problems. Most of them are very simple dental infections. Some of them have abscess, some of them just simply have pain. But really, as we're thinking about how our healthcare spending, the cost, everything's blowing up, these are a whole problem. I see this every day as one of the most fixable problems. Sort of strengthening the partnerships between the acute care health centers or just medical system in general with the dental care world. My question is, what are some of your suggestions for us healthcare providers who are no matter where we are in our training or our career, to really effectively advocate for more strengthened partnership with the dental care world, so we can really advocate for those patients who can really help and support.
I love that question. First, it underscores that you see oral health as health, which is very important. You know, I'll be quite honest. I mean, the dental practice system is a private practice system. Private. Doesn't mean public, it means private. Most are operated as private businesses. If my need doesn't fit the private interests of the practice, I'm not particularly welcome there. I've set my business up in communities that can support financially my business interests. Which means that where I grew up in Harlem, you have few dentists. Ariana's from Gary, Indiana, and I go through Gary, Indiana a couple times a week from where I live in Michigan. It has very few dentists in communities of need because it's private. However, there are dentists who are sympathetic, who want to help. And I wouldn't lose total faith on the dental organizations within the state, but I think they need to be talked with. I think as Dr. Drake mentioned, I think they need to be addressed cordially with an acceptance saying, we need you. And I think there'll be some responsiveness. Whether it's going to be universal responsiveness, I wouldn't put my hopes on it. But to me, it's something that we have to work on collectively. I do not have the answer. I see the barriers. Again, though, we talked previously about dental therapists. That's exactly the role that a dental therapist can play. Short of something that is major trauma or extensive oral surgery, the dental therapist can at least take the load off of those lesser situations in terms of lower levels of need and acuity. And that's what the dental therapists have been proving that they've been effective in doing in these other states. So that's part of the answer, but I think that if you approach dentists or approach dental organizations with this type of need, you put them in a position of having to come up with some sort of response. And I think in that process, you set up a dialogue that could be beneficial over time. Whether it's not going to happen overnight, but it could be certainly beneficial.
So I'll take a, no pun intended, shot at this. Dr. Gray one time talked about Ohio State's band, the best darn band in the land. And he also talked about how we all play a piece, if you will. And so it's all of us, right? The chorus of health equity isn't just on the trombones or the drum major. So it's all of us together. And oddly enough, we can go back and have discussions about this all day. It's almost always physicians in the room. You have 5 physicians of 5 minutes. If you say oral health is important, the crowds would look at physician and say, well, the doctors, if you will, said that oral health is important. So we beg of you to just sort of amplify the story that oral health in fact matters. It is part of health. Same with oral health, intersection of oral health and behavioral health. Those are all important because they lead on to the cost of care, substance use disorder, and everything else that you have to deal with and you see. So that's the first thing. So that's on the like on the bigger picture level. On more of a tactical sense, on a day-to-day, what are we doing as far as the training? I don't know, I think there's definitely movement around co-training physicians and dentists at the same time, but ultimately our paths sort of diverge at some point, if you will. We go different paths, different places. Some of the things that we're working on a lot, quite frankly, is provide the care coordination component and interoperability, health and information exchange, so that the systems can talk to each other. But the representative workforce matters. We know, for example, so I'm gonna go really, really high level at the systems level again, talk about Medicaid and reimbursement rates. One of the things that I constantly talk about is that we need to have real investments and meaningful investments in access. So Medicaid adult dental benefit expansion in a state is fine. When you don't have the money to back it up, the reimbursement rates, when they don't jive, when they don't match, it's not going to be a wonder when you're not gonna have providers providing for those communities that are absolutely left at and held at the bottom rung of the socioeconomic status in the community. And we also know that providers of color are the ones who go back to their communities to help the disenfranchised most. So when I talk about reimbursement rates in the Medicaid adult dental benefit landscape, it is in fact holding the feet to fire of the system broadly to make sure they back it up. And so it's definitely a multifaceted issue that, as was discussed, I think I really, unless we start to really talk about the systems level change, your day-to-day is going to be spent with intraoral abscesses and Ludwig's anginas and all the stuff that you gotta deal with. So great question. Thank you.
So as we wrap up this session, which has been wonderful, thank you all again for coming and sharing your wisdom. You know, it's even from different spaces, we all kind of say the same thing. We need to collaborate, work together. It's both and, right? We need to be innovative in the technology space, but we still need boots on the ground. We need people to touch people, right? And as we think about the workforce development and developing the workforce, but making sure that the workforce is diverse and is really able to empower the people that we're trying to serve. And so for my last question, it's not quite rapid fire, but one sentence, so quick. What are you most optimistic for going forward? I'll give you 2 sentences.
Optimistic that we can close and improve the gap on the disparity within maternal care.
I'll just say the fact that we have oral health providers and physical and behavioral health providers in the same room talking about how health equity is a component and directly connected to racial and social justice. If that's what's good jobs.
I'm optimistic about the energy and commitment in this room that gives me a sense of optimism that we're on the right track. And we need to think about it in terms of, if not us, who, and if not now, when. And we're all part of the answer. And I appreciate spending the time with you.
So Kim is going to give us a few words and then we'll have a presentation of our Vision Award.
A few words.
No,
I'm just kidding.
Look, give me that. And then we'll have a light reception in the back. So nobody leave. And then don't forget, Reed Scholars, we're going to take a picture. So especially y'all know.
Great. Well, thank you to our panelists. You folks were dropping wisdom. And Mary started the session off by saying that she wanted us to be inspired by information and to give us action steps. You said that.
I did.
I wrote that down. And I just wanted to reflect on your 3 presentations, which are fantastic. They lit up my neurobiology. We had to talk about that this morning. And they also lit up my cardiac biology. So, you know, the mind and the heart and how inspiring you were. So just some reflections and then some action steps. So Dr. Evans, first off, thank you so much for all you've done for the integration of oral health and primary care. He was one of the first authors of the integration of oral health and primary care, particularly in federally qualified community health centers. And that is a big trend and focus of community health centers nationwide now. So thank you for that. Some of the things that you said that really struck me up here and here was that power tends to protect status, that principle tends to give up power. Principle tends to give up power. That moved me. And that who benefits from the lack of policy? And that the Surgeon General's report was about findings and data and it wasn't policy. Yet that drove all the policy by you shining a light on the gaps that drove this policy for us within primary care and integration of oral health and medicine. So thank you so much for that. The other thing that you said, you started the National Coalition of Dentists for Diversity. For Health Equity, the National Coalition of Dentists for Health Equity. That struck with me because you didn't have a seat at the table, so you created your own. Okay, you organized. You are not disorganized. You are organized. You are so organized. So thank you for that. So that was some reflections from your presentation. Dr. Kaz Rafia, thank you so much for being a supporter of the Reed Scholars for all these years and for your wisdom. I didn't know that you were a dentist. So I'm so glad because you're doing so much of all this other, policy work and leadership work and health systems. Or I didn't know that you were a practitioner as well. So thank you. I'm so glad you were on the panel. What moved me in your talk was that you said that our current system is broken and that we're leaving out populations. You emphasized this over and over and over again. So thank you for always remembering that in your leadership roles and positions. You also said that your work is data informed and not data driven. That is the first time I've ever heard someone in a leadership position say it's data informed. And that's the most important, not being data driven, because the community voices that are going to contextualize that data is as important or more important than just being data driven. So that was key. And that came out in some of the questions about the AI and what the data sets are, what's driving this generative AI, which I still don't quite understand, but the data sets that are driving it and making sure that those community voices are at the center. So I really applaud you. I thank you. That moved me. I am so glad that you're here. Can we make him a Reed Scholar? You also said that you wanted us to cultivate a network of advocates and apostles. So bringing again, Dr. Joan Reed's idea of faith. You mentioned apostles. So, bringing that in and really this is that it's a calling. And you also said innovation is a new way of doing things. But then you said, actually, we need to renew our deeper calling. That faith, that heart, that mission of why we are all here in this room. And calling that, it's not making something different. It's about really tapping into what makes us here different. So thank you for that. I was really moved by that. And Ariana McGee, wow, you were in Rent on Broadway. No, I'm just kidding. I was really moved and really inspired by you calling in your ancestors, by you calling in and tapping into what is deeply rooted and seated in you. And Louisa Bowers Calloway, that she was the first licensed midwife in which state? I'm sorry, I didn't.
One of the first.
Which?
Louisiana.
In Louisiana. And that she had no agency of her own in her reproductive health. But then she became the facilitator for others to have that, using her own personal experience and oppression, I think, to help support others and move them forward in their journey. So paying it forward. And we can see that here today when you calling her forward and all the work, amazing work that you're doing. I was also moved by the fact that you, in the story about your great-grandmother, that they changed the requirements that she had to be licensed, or the midwives had to be licensed. And that was a way of blocking people through policy. So again, what Dr. Evans had mentioned before, blocking people like her from being able to do the work and her calling and her mission, but she became licensed anyway. So go grandma. So we prepared for this, and using your personal narrative and your storytelling and your great grandmother's narrative and storytelling, and using that personal experience to inform all of the great work that you're doing and the innovations, showing how it's leading to policy changes, the 12 state from the states with 12 months of postpartum care. That's incredible, from 3 to almost all of them within a span of 3 years. Is that right? So people like you and the work that you're doing, creating that policy change from the ground up. So really, I was inspired and moved by that. You are the change that we want to be and want to do. So thank you for sharing your story with us. So some action steps. You can hear some of the key themes. They're different topics in a way, but everything is, there's some themes that and ways that they shared their stories and experiences. So first, renewing, that's our first action step, renewing our deeper calling and our mission. Second, organize. Mary creates a space for professionals in her leadership for health equity, professional development, that Harvard course. She creates spaces for others. You folks are creating space here. I heard Dr. Connor call for us to organize and creating that space and organizing together. We don't get policy change unless we have the people moving it and backing it. Second, get a seat at the table or create your own. And third, use our personal narratives. Don't let anyone tell you that your experience isn't valid, because that's the only thing that is valid, that is going to move others, and you tapping into your own personal power. And finally, policy is nothing without our advocacy and our data and the people moving it. So, we talk about policy, but it's really all about us and the work that we do together. So thank you so much. Now we can get some refreshments, I guess. I'm ready to call Mary back up. Thank you. It was an amazing panel. Thank you so much.
Thank you, Kim. You did amazing. Oh, you did. Okay. Okay. Oh,
On behalf of
Dr.
the
Hodge is gonna
board
do a presentation.
and all Reed scholars, we just can't thank you enough. This was a wonderful, wonderful symposium, and the words are gonna resonate with us for a long time. We want to give you these small gifts as a token of our appreciation. And Don will show you that we really appreciate it. Don.
What?
Oh, I get what you do.
No, that's fine. As Dr. Hodge is giving out our gifts, we did have one question, or it's a comment from Dr. Curry. Change has been slow and incremental and has come at a cost in terms of sicker lives and lost lives. Ms. McGee's point about maternal health from 1990 to today and Black women's health outcomes is real and weathering. What is this? There is a question in there, sorry. What is the disruption we need to ensure quality access and affordability is realized in our lifetimes? Then there's a haymaker. So I wanted to acknowledge that question. We don't necessarily have time to answer it, but I think we discussed a lot of those principles during the course of the conversation. Again, doubling down on Dr. Hodges' thank yous for being here, participating, engaging in the conversation. And hopefully this continues the conversation towards collaborative action and policy change. Some of you all will be with us for the rest of the evening. Yes, okay, good. But if you can return, you don't have to sit up if you don't want to. You're welcome.
They're gonna join us at the soiree tonight.
Yes, we'll keep the party going. We will. We have one more thing on the program and then we'll do our photo ops. Our last agenda item is our Vision Award. So each year we give a Vision Award to an individual who we feel embodies the mission, vision, and values of what the Reed Scholars represents as an organization. This year, we are giving it to our esteemed treasurer, Dr. Don Lee. I had to get, I was thinking we were gonna ruin the surprise, and I kept saying, who's getting the Vision Award? I said, I've got it taken care of, Don, leave me alone. But Don is, I guess we could say he's part of the original group, as he'll tell you, he was around as a research fellow when the fellowship started. He will also tell you how old he is, and every time he does, I'm like, you can't be, but he looks 12. But Don came back and has been just a godsend for me and for Reed Scholars as we continue to build the organization, build our treasury and our fundraising, helps keep us organized, ask us the hard questions. And so we really appreciate you coming back, staying committed, and everything that you do at home. He comes from Wisconsin, where he's been just finished president of the Wisconsin Medical Society. Did I get it right? And so he did both of those things, which were very heavy lifts from a leadership perspective, but he keeps health equity centered in everything that he does. And I know Reed Scholars is always in your heart, so I appreciate you. So the award reads, if I can open the box. I should have pre-opened it. It says the Reed Scholars presents the Vision Award to Don Lee, Treasurer and Chair of our Capital Development and Management Committee, in grateful appreciation for your tireless commitment and strong work, giving us a solid financial foundation.
One word. I have to thank Mary and the team. It's been a great team to work with. And I want to thank, the smartest thing I ever did was to pick team members, right? So Cynthia Hodge, Ralph Facillo, Brian Swan, and the previous treasurer, Kavita Prakash, and to have them on my team, that this award belongs to them as much as me. Thank you so much. It's just been great. And then, of course, the person who nominated me, please stand up, because I don't remember who you were, but whoever nominated me for treasurer, thank you. So.
Four more years.
Okay, sorry, Jeff. Jeff keeps us together. Okay, all right, okay. I'm gonna say one last thing to Kimberly Chang. She was like, what am I supposed to do? I don't know how to be a commentator. Didn't you do a great job? Thank you. So with that, I will ask the speakers to come back up first, and we'll take a picture, followed by the Reed Scholars, and we'll take a picture. We do have refreshments in the back, so please help yourself to that. As you probably noticed, because some of you have gotten 1,000 emails in the past 3 months, this is my 10th year as president, and so we are going to have a little celebration tonight, because I think it's important for us to be smart together and party together too. So we're going to party with a purpose, all right? So I invite you, if you're not already planning to attend this evening, and we're going to have a good time. So with that, I bid you adieu, and I appreciate your time and attention this afternoon.